A hearty good afternoon and welcome to the session on things to know all about IVF. We are glad to have Dr. Aruna with us among today and she will help us understand the topic. She will take us through that and more in this session today. Doctor, you have the stage.
Hello everyone, this is Dr. Aruna Sahadev from Apollo Fertility RR Nagar. Would like to continue the session of things to know about IVF, which I had already done, I think a month or 2 months back. So, as a continuation of the previous video, I just want to discuss about IVF procedure as such and terminologies what we use in IVF and probably to certain extent of IVF success rate and the failure rate. So, what is IVF procedure? So, as we know, when the patient is selected for an IVF procedure, so there are certain prerequisites, as I already discussed about the indications for IVF. So, we will talk about the prerequisites of IVF, like what exactly is required before we start an IVF in both husband and wife. So, what are the prerequisites? There are certain female investigations to be done before we start IVF. Could be a basic routine CBC, random blood sugar, or glycosylated hemoglobin, or hormonal profile like FSH, LH, prolactin levels, and her AMH levels. So these are and thyroid levels. So these are the 4 to 5 basic hormonal levels to be performed before we start IVF procedures. Or if at all, if the prolactin levels are high or thyroid levels are high, it has to be corrected before we start IVF so that there should not be any problem with the oocyte quality when it correlates with the IVF when we start the cycle. So next, coming to the basic ultrasound, what we do on the second and third day, where we are looking at the antral follicle count, or is there any presence of retention cyst. The cysts are the one which are the water filled, the follicle which are present. The thing is, usually there is one egg which ruptures in the each cycle, but certain follicle which remains even for the next cycle would form a cyst. So these cysts, if they are retained and if they are start producing estrogen from the second or third day, we can't start the cycle the same month. So that is why we do scan on the second and third day to rule out there are any presence of hormonal cyst, or which is also called retention cyst, or if there is any an endometriotic cyst which was already present or it has occurred recently. So these are this is an indication why we do an ultrasound on the second and third day. And the coming to hysteroscopy, the few patients we do hysteroscopy before we start IVF. That is when there are previous abortions, or if there is any previous history of the history suggestive of tuberculosis, like genital tuberculosis, where the patient complains of irregular periods or decreased menstrual flow, or maybe a absence of flow. So, and then there is a long history of infertility, maybe a 10 to 12 years of infertility, and there is a history of recurrent implantation failure. So, we would like to rule out genital tuberculosis, or maybe adhesions, or there is a polyp, or maybe a fibroid within the cavity. So, this is why we do hysteroscopy prior to start IVF in a very few, in few cases as of now. So then coming to diagnostic hysterolab. So diagnostic hysterolaparoscopy is also advised for few patients, okay, who are a case of an endometriosis, which we would have find out in during a scan, and to if at all if the endometriosis is more than 3 centimeter, the surgery has to be done. So we usually do a laparoscopic endometriotic cystectomy. Along with, we try to mobilize the ovary so that it is accessible for an ultrasound as well as for the oocyte pickup, and do adhesiolysis, because usually endometriosis is associated with pelvic adhesions. So adhesiolysis has to be planned along with the endometriotic cystectomy. So this is what why do we do a hysterolab, and other one is to sometimes the patient come with an HSG report of bilateral tubal blockage or a single tubal blockage. So this can be confirmed by doing a hysterolaparoscopy uh, in the previous cycle, not on the same cycle, on the previous cycle, so that we come to know exactly if there is any bilateral tubal blockage or a unilateral tubal blockage, and how the tubes look like. See, if the bilateral tubal blockage is there, nothing can be done. If it's a unilateral blockage, we can try chromopotamine. We can try with fallopian tubal catheterization can be tried. That is only if there is a proximal tubal block, not the distal tubal block. So, and on a hysteroscopy, we can actually look at the how the tubes look like. Okay, how do the, I mean, appearance of the tubes. See, the tubal physiology, I mean, tubal function is more important than the appearance of the tube. Okay, so if the functioning, I mean, when we do a chromoperturbation on hysterolaparoscopy, there should be a free spillage. If the spillage is low, or if there is a beaded appearance of the tube, that means the tube is already damaged. And already, I mean, there's nothing like unilateral damage. It's most of the time it's a bilateral tubal damage, because infection can't happen in one single tube. It should be all the time both the tubes are damaged together. So maybe the severity is different in different tubes. So maybe the one tube gets affected first, and maybe the other tube gets affected a little later. So we this has to be ruled out when we do a hysterolaparoscopy. That is in the previous cycle, the previous month, not on the same month. So this is what regarding the prerequisites, what we do it for most of the female patients. Other than that, maybe a special test can also be done, like karyotyping can be advised. That is only when the patients is already have recurrent pregnancy losses or previous baby has some issues. So we would advise karyotyping for both the couple. Sometimes with thrombophilia workup can be done for, if at all, the same thing, if there is any recurrent pregnancy losses are seen in the previous pregnancies. So then coming to male partner. So what are the things we usually advise? So after finishing the history, we come down to the investigations. Like usually we advise the same thing, routine complete hemogram, and random to rule out his sugars, random blood sugars, and glycosylated hemoglobin, and a viral screening. Viral screening is must for both the patients, for both the partners. It has to be done. So viral screening, and the basic semen analysis is performed. So the semen analysis we either categorize into a normal semen count, or probably a severe oats, or an azoospermia. So what is severe oats is where we have the count. There are, I mean, there is a disparity in both the count, the motility as well as the mortality. It's called a severe oligoasthenoteratospermia, or other one is azoospermia. So what is azoospermia? Azoospermia is absence of sperm in the semen, which we have checked in the two different occasions. Okay, there is an adequate between the two occasions. So this is called, I mean, azoospermia. So the azoospermia can be two types. That is obstructive and a non-obstructive variety. So obstructive variety is mainly because of an acquired infections, or maybe a surgeries, or there is any trauma. And the non-obstructive can be because of congenital, or could be because of post chemotherapy, post radiotherapy. So these are the and some hormonal imbalances which has happened, or maybe a post depression medicines, and so the other antipsychotic medicines which he's been on. Okay, so that is for non-obstructive azoospermias. And severe OATs, the patients are usually treated with certain degrees of antioxidants. So when we do a analysis in the previous month, and if it shows a severe OATs, we usually put them on 1 or 2 months of antioxidants prior to take them for the IVF procedure. Okay, and in an azoospermia, when we find out on the analysis, so we usually tell the patients, see, if they are very keen about using their own sperms, so we advise to do a trial TISA, which is called testicular extraction of the sperm. So basically, it is done under local anesthesia by an andrologist. So where, if at all, if we found an adequate sample on TISA, though we usually time it as a non-obstructive, obstructive type of azoospermia, and we usually, I mean, if the sperms are adequate and they are good looking, we freeze the sperm sample. So that can be used for the further IVF, and the patient has to undergo an IVF because the TISA sample can't be used for an IUI procedure. So this is regarding azoospermia and severe OATs. Okay. So the trial TISA is done always prior to the cycle. So next, coming to trial TISA or trial PISA. So which is basically done under local anesthesia by an andrologist, and which is really non painful procedure, which can be done as an OPD procedure, which is hardly takes half an hour to 45 minutes. The thing is, the testes are held, and then they usually, with the small micro needle, the sperms are, the spermatic cords are aspirated, and they're sent it to the lab, and where they do the teasing procedure and remove the sperms and look for morphology and motility and viability. Okay, so the ones the sperms are adequate in number, they usually freeze the sample and keep it as a backup sample for the coming IVF cycle. So this is what it is, and usually fresh TISA is always preferred to do on the day of IVF rather than using the frozen sample. If the frozen, if the I mean on the day of procedure, if the husband is not able to come, or probably the TISA sample is not good enough, so we usually prefer to take a frozen sample itself. Then coming to the procedure as such. So now we have come to a situation where we have to know how the procedure is done. So there are so many doubts the patients usually commit, like how do you start the procedure and how it goes. Or so the IVF procedure, as I so once the okay now the couple is assigned, okay, we have started the IVF to you. So usually we advise them to come on day 2 or day 3 of the cycle, and on the day 2 and day 3 we do an ultrasound and look for an we do the ultrasound and look for the AFCs, as I told you, it's called antral follicle count, and look for any presence of retention cyst. And we do few hormonal tests on the day of starting the stimulation. That would be estrogen levels, her luteinizing hormone LH levels, and the progesterone levels. So these three levels are usually done on the day 2, and then the stimulation is started on the day 3. The values are within the normal range. We start the stimulation from the day 3 and go on until day 10 or day 11. So that is basically depending upon the size of the follicle as well as on the hormonal levels. So at least 2 to 3 times we do an ultrasound on them, and we would usually add few drugs along with the regular stimulation with the gonadotropins also, so that until on the 11th or 10th or 11th day, when the adequate size of the follicle has reached, we do give a trigger, which is also an injection, which is given 36 hours prior to the pickup. So the pickup is done on the 35 or 36 hours later, and it is done in an IVF center. The patient has to come nil per mouth, so usually around 8 to 10 hours of nil per mouth, and it is done under a general anesthesia, that is a short general anesthesia. Basically, it is not a regular where the patient will be sleeping for a longer time. It will be for a short period of time, and the pickup is done under an ultrasound guidance. So once the pickup is done, the patient is shifted to a recovery room, and she's observed for 3 to 4 hours. And usually the post-op, if at all, if we tend to aspirate many oocytes, okay, that is more than 10 to 15 or something. So usually the other medications are also given to see that the patient not goes for or OHSS or the ovarian hyperstimulation syndrome. And after the patient passes urine, and she gets up and walks, then, and if she takes orally and if she's tolerating orally, then probably we can discharge the patient with few post-op medicines. Basic antibiotic and painkillers would be given. Unless if she is hyperstimulated, there are certain other medications to be given so that she doesn't get into OHSS. Okay, so normally the follow-up scans are usually done on the 3rd or the 4th day of the pickup, and if she's fine, we ask them to wait for the next periods. Okay, then after the following periods, we plan for doing a frozen embryo transfer. Usually the fresh transfers are not done nowadays, so that is ideally because of the increased hormonal levels, and the frozen embryo transfers have better implantation rate and better pregnancy rate compared to fresh embryo transfers. So that's the reason why the frozen embryo transfers are preferred over the fresh. So next, coming to the embryo status, you see, once we do the pickup and give the eggs to the lab, and the usually the embryologist tease the follicles from the cumulus and then get the eggs out, and they start after 4 hours they start doing something called ICSI. Okay, ICSI is basically intracytoplasmic sperm injection. So this is basically we are selecting the sperms and from the semen sample, and we inject the sperm directly into the egg, and we wait for the egg and sperm to get fertilized in the next day. So this is called ICSI. And IVF is basically in vitro fertilization, where we don't select or anything. We just need to put the egg and the sperm in one petri dish and allow it to fertilize by itself. The ICSI is preferred over IVF nowadays because ICSI has better fertilization rate and the pregnancy rate compared to IVF. And IVF, there are a lot of the reasons why the fertilization will not happen. Okay, and next, coming to like after doing an ICSI, so usually the embryos are cultured and they usually observe after fertilization, and then they look on the day 3 and the day 5. So normally, most of the labs are looking for blast culture nowadays. So because the blastocysts are the very good embryos and they have a very great implantation rate and the pregnancy rate. So those embryos which have been going up to blast are the one who are higher pregnancy rates also. So the ones on the day three, we do observe how many embryos are there and how many grade A embryos, grade B embryos, and most of the time if the embryos are very less, because maybe there are like 2 to 3 embryos, we don't take a chance of going to blast, and we do transfer day three only. But if the embryos are in good in number and they are already, I mean, she's an elderly patient and previous pregnancy failure and all this is there, we prefer to go to blast and then give her a chance of pregnancy. So the blast is, I mean, the blast culturing is done, and the embryos are frozen at the day 5 and looking for the grade as well as the quality of the embryos, and they grade according to the, I mean, there are certain criteria to be taken into account for the grading of the blast also. We can discuss it in later videos. Okay, so this is regarding in short regarding the IVF procedure, what do we do. And there are other things like something called PGS and PGD. So this has become more common nowadays. It is called pre-implantation genetic screening or pre-implantation genetic diagnosis. So this is basically done for those couple who have been already have a child with some genetic abnormalities, or maybe we are suspecting some genetic abnormalities. Battery server is on, and basically we are so when the couple is already an elderly couple and we do suspect, okay, maybe there may be some genetic disorders, so we do advise for them to have a PGS, or previous there is any recurrent implantation failure or recurrent pregnancy losses, we advise them to have a PGS. So it is basically pre-implantation screening where the one of the cells from the blast or the embryo are taken as a are biopsied, and they are sent for a lab for the for the further test, and usually it takes around 25 to 30 days for the report to come. So we usually plan for frozen embryo transfer after the report of PGS comes. And PGD is done basically where we already know there is certain amount of disease which is running in the family, or the previous baby is already suffering from genetic disorder. So we diagnose that particular disease which is present in that embryo or not. Okay, that is called PGT. So this is about PGS and PGT, which it's an in procedure which is performed on the embryo before implantation, or before we put the embryo into the uterine cavity. Okay, so this is what is about IVF procedure in short. Hmm? So then coming to few terminology, sometimes we speak and the patients are not aware about it and they keep asking me. So about few abbreviations like IVF. What is IVF? Is in vitro fertilization. What is ICSI? It is intracytoplasmic sperm injection. And what is TISA and what is PISA? As I already told you, it is testicular epididymal sperm aspiration, and percutaneous epididymal sperm aspiration is PISA. This is which is done under local anesthesia. And there is certain other words called IMSI. IMSI is this is basically it is called intracytoplasmic injection of morphologically normal sperms. So see, basically it is done for those uh, husband whose sperm morphology is very much abnormal. Okay, maybe it is less than 1%, where we need to select which are highly normal sperms. So morphology is basically we are looking for the, I mean, the normal head, neck, body, and a tail. So we are looking for good morphological sperms that can be selected under higher magnification, more than 15 times the magnification we use to select this. This is called IMSI. And then coming to Pixie. Pixie is basically a physiological ICSI. So here, what do we do is we put the sperm into a dish which has hyaluronic acid, which is present on the oocyte. So where here we select the sperms which are getting attached to hyaluronic acid, so that these are physiologically normal sperms. See, normal sperms should get attached to hyaluronic acid. So this how we are highly selecting the sperms which are physiological. Okay, this is called PIXI. This is also done for those patients who are having a highly low motile and low morphology in their semen count. Okay, so this is one of the other one. Other one is a DNA fragmentation index, which is nowadays performed to most of the couples who have recurrent abortions and previous pregnancy losses or probably previous IVF failures. We do as a routine test for the male, which is called DNA fragmentation index. So this is basically because of oxidative stress, the DFI levels will be very high. So there are certain things what to be done for high DFI also that can be discussed later. The other thing is ERA. ERA is one more thing what we perform before implanting the embryos. So it is called endometrial receptivity array, where it is done uh, in case of recurrent implantation failures, even though with the good embryos and good endometrial lining, the couple is unable to conceive, or whether the implantation is not happening. So to time the exact able to time the exact transfer, we do what is called ERA. So this procedure can be discussed in the later videos also. It is beyond the scope as of now. So this is basically, in nutshell, I've tried to cover about the IVF procedure, the prerequisites, and few terminologies. So in the next video, I would try to tell you about what can you expect about the IUI success rate and the failure rate. Yeah, thank you for the patient hearing.